just type great if you can see me, so that I can know कि I'm visible and live. So we had already discussed part 1 of the NEET PG, not NEET PG, but AIIMS examination previous year questions, and this will be a very important part where we are going to discuss a lot more good things about your AIIMS PG. So whatever have been asked and what they can ask you in your future NEET PG examination, today we'll see all those questions. So that is why we already explained why it is important to study previous year questions, because most of the topic remains same, but they anticipate future questions from same topic. So it has been a known trend that they will be asking questions from previous year topics but newer ones. So you need to know the topic to mark the answers right. So this we had discussed just a fast follow-up of the questions. Here they had asked about pyriform fossa. You all know bilaterally this is pyriform fossa, a laryngoscopy picture. These two are, so you can always comment. I'll see your comments in the comment section. These two are the vocal folds, true vocal folds, and these are the false vocal fold. So initially we used to say vocal cord, now we say vocal fold. This is epiglottis. And what else you can see? Arytenoid, aryepiglottic fold. And this is basically a picture of laryngeal inlet that you see by the laryngoscopy after doing the laryngoscopy. Now this is a cut section, sagittal section, where you can see the hypopharynx. So basically pyriform fossa is a part of hypopharynx. Epiglottis, laryngeal inlet, aryepiglottic fold, arytenoids, interarytenoid region, and oesophagus is starting. Here they had asked about aganesi, that is the anterior most ethmoid cells, aganesi cell, right? So I had told you about diagnostic nasal endoscopy. You should be familiar with. They can give you a video of diagnostic nasal endoscopy in your future exam. Here you can see the anterior and posterior ethmoid cells and the frontmost cell, if pneumatized, is the aganesi cell. So why aganesi cell is important for endoscopic sinus surgeons? Because it leads a pathway for the frontal sinus. So if you have to reach the frontal sinus during endoscopic sinus surgery, these aganesi are present in the frontal recess, means pathway to the frontal sinus. So these aganesi cells are important landmark to enter into the frontal sinus, right? So these many a times pneumatize into the frontal sinus, and to reach frontal sinus proper, you need to open these aganesi cell and enter into the frontal recess and then into frontal sinus. So if you see, this is your frontal sinus proper, and this is your pathway. The way is the frontal recess, finally opening into the aganesi. Here also the anterior most cell is aganesi. We also talked about anterior ethmoidal cells. The landmark is the Kennedy's nipple, which is present between medial rectus and superior oblique. So I am a bit fast here because we had already discussed it in the part 1. Just for revision, a formal revision, we are doing this. So just in the comment section you can let me know if anything is unclear. I am seeing it. So this is mastoid Mollison retractor, self-retaining, hemostatic. Okay, why self-retaining? Here there is a grip and it is self-retaining. Hemostatic because due to pressure it prevents the bleeding from the blood vessels. Now here also you had observed about the prosthesis for voice production post laryngectomy. So very new and important topic is post laryngectomy rehabilitation. So there are different means. One is oesophageal voice, which is natural. You train the person who had undergone a laryngectomy for oesophageal voice. And what benefits it? The benefit is no extra surgery. Like for tracheoesophageal prosthesis insertion, you have to make a fistula, tracheoesophageal fistula. So usually it involves a surgical procedure, while the oesophageal voice is the natural voice which the patient acquires by training. What he does is he inhales the air or swallows the air, keep it in somewhere around the pharynx, and then with pressure that air comes out in the oral cavity, and with movement of tongue the speech is produced. So the oesophageal voice appears in bursts. That means he will speak but in short sentences, in burst. So this is oesophageal voice. The voice is not much clear. The best voice that you can produce is by the tracheoesophageal prosthesis, right? So these all Blom-Singer prostheses we had discussed in detail in the last session. This is the oesophageal voice, this one. The physiology is swallowed air, whatever the patient has swallowed is expelled out, causing vibrations of the pharyngeal mucosa. And these, with the help of articulation of tongue, causes production of voice. Electrolarynx is a battery operated instrument which causes electrical stimulation of the muscles, resulting in production of speech. The drawback is robotic voice. It will appear like a robot is speaking. So if they ask you an exam, they will give you an instrument like this, or a video clip where the patient puts this instrument below the chin to produce voice. So robotic voice, battery operated, costly. So these are some of the drawbacks of these electrolarynx. Now coming to the future question that was left. So this is very important questions with regard to ENT, and every year there is something with regard to thyroid surgery and recurrent laryngeal nerve. So some question they are going to ask from it. So if you concern this question, let us read it. Which of the following structure has chances of least injury during thyroid surgery? Recurrent laryngeal nerve, superior laryngeal nerve, ansa cervicalis, marginal mandibular nerve. So if I ask you, can you tell me the answer? Yes. So the answer here is marginal mandibular nerve. Now why I am saying this? We had to go through the anatomy, because if you don't know about the anatomy, you will not be able to solve the future questions they are going to ask from this topic. Now let us see this picture. Here you can see the thyroid cartilage. Okay, the thyroid gland, a butterfly shaped gland, right and left lobe of the gland. So beautifully placed thyroid gland, and what you can see here is two nerves. One is along the lower pole, another is along the upper pole, right? So the lower pole, in relation to the lower pole, a nerve is coming out from the vagus, encircling the subclavian artery on one side and aorta on the other side, and moving in relation with the thyroid along the tracheoesophageal groove and entering into the cricothyroid joint. So this is the normal course of recurrent laryngeal nerve. It enters and ends at the cricothyroid joint. So during surgery also we need to identify this recurrent laryngeal nerve. So as you see, it is very close proximity to thyroid and high risk of getting injured while removing the thyroid. Coming to this nerve, which is the external branch of superior laryngeal nerve. This one is external branch of superior laryngeal nerve. Internal branch, gives sensory supply to the supraglottis, the part above the vocal cord, and the external branch is motor branch. So it also lies somewhere near the upper pole. So again in relation to thyroid gland and in risk of getting damaged during thyroid surgery. So both recurrent and superior laryngeal nerve are in close proximity and in risk of damage to the thyroid surgery. Okay. Now coming to the ansa cervicalis, the third option. So if we see this ansa cervicalis nerve, here you can again see that it is in the area of thyroid. So again it is also in relation with the thyroid gland. This is a cadaveric section where you can see the sternocleidomastoid muscle is retracted, the internal jugular vein is retracted. This is the omohyoid muscle, and here you can see different branches and segments of the ansa cervicalis. So this is the superior root of ansa cervicalis. This is the inferior root. This is our external carotid artery, and somewhere here will be thyroid gland. So again you see it is present near the thyroid gland in relation to the bed. So if you means if you retract the internal jugular vein, this ansa cervicalis is present medial to it. So always there is a risk of injuring while doing the thyroid surgery and while doing the neck dissection. Now what is left? One nerve is left, which is the marginal mandibular nerve or marginal mandibular branch of facial nerve, which we said is not involved in thyroid surgeries, means not in risk of damage during thyroid surgery. Why we said that? Because if you see, this nerve is present along the ramus of the mandible here, somewhere here. So while doing the thyroid surgery, we are operating in this region below the hyoid, and this nerve is present above the hyoid. So this nerve is in least risk of damage during thyroid surgery, and it becomes our answer of choice. Now coming to one future question, then when there is a risk of injuring the marginal mandibular. So write me in the comments when you will suspect a marginal mandibular nerve injury in which all surgeries. Okay, right. So in submandibular gland resection, submandibular gland excision. Okay, so in submandibular gland excision, in case of neck dissection, when you are elevating the flap or you are working somewhere here in the submandibular triangle, then there is a risk of damaging the marginal mandibular nerve. Okay, and that is why while elevating, while giving the incision, we take care of this marginal mandibular nerve. Okay, so in these two operations, whenever there is any pathology of submandibular gland like submandibular duct stone or stone in the gland itself or any neoplastic lesion of submandibular gland, you need to remove it, and then you need to take care of this marginal mandibular nerve. So see how this nerve is very fragile, and what will happen if this nerve is damaged. So they can give you a clinical scenario where they will say patient had undergone a submandibular gland excision due to a submandibular gland carcinoma. Patient after the operation observed what he observed. This nerve was supplying the angle of the mouth. It was responsible for equal deviation of the equal extension of the mouth. So he will observe the deviation of angle of mouth. So what nerve can be injured? So you should point towards the marginal mandibular nerve. So probably this nerve was involved with the cancer or due to the iatrogenic means injury caused by surgeon. So during elevation of the upper flap, the surgeon might have injured this very thin and fragile marginal mandibular nerve. So by now you know when this nerve can be injured and why you should know that this nerve is important. Now, going back to the recurrent laryngeal nerve and superior laryngeal nerve and the thyroid surgery, as they have touched this topic, in future they can ask you questions based upon different triangles that are present in relation to thyroid gland. So I'll demand 2 minutes more concentration of you in this triangles or in relation to the thyroid gland. Now there is a triangle called Behers triangle or Riddle's triangle. So for both recurrent laryngeal nerve and superior laryngeal nerve, there are different triangles. And why it is important to read about this triangle is because the surgical concept of operating on thyroid gland has changed. So initially you remember we were talking about tying the arteries near to upper pole and far from lower pole or vice versa. So this concept of tying the artery to preserve the nerves near and away from the poles have gone. What is the concept now is the concept is identify the nerve. That means you need to identify the recurrent laryngeal nerve and superior laryngeal nerve and preserve them. So the initial concept of just excising the thyroid gland and tying somewhere is no more prevalent nowadays. Now you have to identify the nerve. So if you see the nerve, there is less chances of injuring the nerve. So the same concept applies here. So you need to identify the nerve and preserve the nerve. So whatever eyes sees, brain can preserve. So here the concept reverses. So you need to see to preserve the nerves. And that is why these landmarks and these triangles are important. Now what is important is you should know which triangle is for which nerve. So Beher's triangle or Riddle's triangle is for recurrent laryngeal nerve. And what are the boundaries? So any triangle has three boundaries. Okay, one medial, lateral and one upper. So if I form a triangle like this, one will be the medial boundary, one will be the lateral boundary, and one will be the superior boundary, right? So what is the medial boundary? In Beher's triangle, the nerve itself, like if you see, yeah, so the nerve itself, that is the recurrent laryngeal nerve itself, form the medial boundary. The other two sides are formed by the inferior thyroid artery and the common carotid artery. So one side is recurrent laryngeal nerve, superiorly is inferior thyroid artery, and other side is common carotid artery. So it will be more clear if you see this. So recurrent laryngeal nerve in the lower part of tracheoesophageal groove forms the medial boundary. See, this will be your Beher's triangle. So somewhere here will be your recurrent laryngeal nerve. This is your common carotid, the lateral boundary, and superiorly is the inferior thyroid artery. So how you are going to identify this nerve? During surgery, you first need to identify inferior thyroid artery. Okay, this will be your first landmark. Second will be identifying the common carotid artery. Now as two borders have been identified, you will search for the third boundary, that is recurrent laryngeal nerve. So if you find these inferior thyroid artery and common carotid artery, which are easier to find, you know that recurrent laryngeal nerve will be somewhere in medially located, and then you can identify the nerve and preserve it. So Riddle's triangle and Beher's triangle are for which nerve? Comment. It is for recurrent laryngeal nerve. So don't mistake it or forget it in future. Now for superior laryngeal nerve, the external branch of superior laryngeal nerve, we have another triangle called Joll's triangle, right? So Joll's triangle is at the upper pole of the thyroid, and again like a triangle it has several boundaries. So superiorly, if you see, will be the strap muscles. Strap muscles mean sternohyoid and sternothyroid. So these strap muscles will be above, okay. Floor below will be cricothyroid muscle. The lateral boundary. Lateral boundary means laterally will be the upper pole of the thyroid and superior thyroid artery. This is your superior thyroid artery supplying the upper pole of thyroid. So this forms the lateral boundary. Medially is the midline. Okay. Laterally is the superior pole of thyroid and the superior thyroid artery. Midline. Superiorly is the means above will be the strap muscles and floor will be the cricothyroid muscle. Now the nerve, if you see the nerve color, so color is for nerve it is yellow. So nerve will be somewhere, okay, yeah, so nerve will be somewhere in the content of this triangle. So Joll's triangle, the nerve, wait, this yellow color is not much visible, yeah, so this nerve will be somewhere in this triangle. So Joll's triangle is for external branch of superior laryngeal nerve. Okay, so laterally revising the upper pole of thyroid and the superior thyroid muscles. Superiorly is the strap muscles. Medially is the midline. Floor is by cricothyroid muscle, and external branch of superior laryngeal nerve lies within this triangle. Right now, there is one more triangle for recurrent laryngeal nerve, and which is called Siemens triangle. So just know the name. You need not to remember the boundaries. You will confuse. Just know the name that Behers triangle, Riddle's triangle, Siemens triangle. These all are important triangle with regard to recurrent laryngeal nerve. Right? Joll's triangle was for superior laryngeal nerve, and one more triangle is called Loray's triangle. Again, it is for recurrent laryngeal nerve. So here, what is the difference between the boundaries of Loray's triangle and Behers triangle? In Behers triangle, the recurrent laryngeal nerve was forming one of the boundary. The medial boundary was recurrent laryngeal nerve. In Loray's triangle, recurrent laryngeal nerve is the content of the triangle. Okay. So how? Here the medial border will be trachea and oesophagus. Lateral will be the carotid artery. Superiorly will be the inferior thyroid artery, and in this triangle you will find the recurrent laryngeal nerve. So if you see here, this is your midline, which is trachea and oesophagus. Trachea or oesophagus. This is your inferior thyroid artery, and this is your common carotid artery, somewhere like this. So inside this content will be the recurrent laryngeal nerve inside the tracheoesophageal groove. So Loray's triangle again for recurrent laryngeal nerve. Now there is one more triangle which is of concern for surgeon, and that is why it is called triangle of concern. Why it is called triangle of concern? Because the risk of bleeding is very high in this triangle. Why high? Because middle thyroid vein, inferior thyroid vein, branches of inferior thyroid artery, all of them are lying in this triangle of concern. So that is why, just remember, this triangle of concern is of concern because of high risk of bleeding in this area, presence of middle thyroid vein, inferior thyroid vein, and inferior thyroid artery branches. So this is the Joll's triangle, which was for external branch of superior laryngeal nerve. This is triangle of concern, and this is our Behers triangle. Just a schematic diagram to show you the different triangles in relation to thyroid and its surgery. Also, before finding the external branch of superior laryngeal nerve in the Jaws triangle, what we were doing is we had to do dissection in that part, and it is always better to dissect in cricothyroid space of Reeves. So what is this space? This is basically a avascular space. So anytime if you operate on patient, you will want less bleeding. So that is why we open the fascia in planes, and this is a avascular space. That means it does not contain, or it contains less blood vessel, so less bleeding. That is why this cricothyroid space of Reeves is favorable for finding the external branch of superior laryngeal nerve in Jaws triangle. So it is a avascular space between the upper pole of the thyroid and the cricothyroid muscle. Cricothyroid muscle was the floor of Jaws triangle. Upper pole of thyroid was the lateral boundary of Jaws triangle, and it helps in avoiding injury to the surrounding important structure and less bleeding due to avascular space. So cricothyroid space of Reeves. So in this short time we had discussed so many of important things like Beher's triangle, Riddle's triangle, Lore's triangle, Jaws triangle, cricothyroid of space of Reeves, triangle of concern. So summarizing, Beher's triangle, Riddle's triangle, Simmons triangle, and Jaws triangle, and this, that is Lore's triangle. So Beher's, Riddle, Simmons, Lore's, these are for recurrent laryngeal nerve. Joel's triangle is for superior laryngeal nerve, right? And the two simple rules in larynx you all remember, just want to revise you for all, is all the muscles of larynx supplied by recurrent laryngeal nerve except one. Can you name me this muscle? Except one, that is cricothyroid, which is supplied by external branch of superior laryngeal nerve. So this is one. Another is the only abductor. All the muscles are adductor, and the only abductor is posterior cricoarytenoid, which is supplied by the recurrent laryngeal nerve. Okay, and what is the function of this cricothyroid, which was supplied by the external branch of superior laryngeal nerve? This is a tensor of vocal cord. Tensor of vocal cord. So this half an hour session is also ending. I want to discuss all of them, so I'll be little fast. Now, a child presents with a high grade fever, inspiratory stridor, develops swallowing difficulty with drooling of saliva since last 4 to 6 hours. Which of the following treatment is recommended apart? So here the thing you need to underline is apart from general airway management. So let us see the option. Nebulize racemic epinephrine, anti-diphtheria toxin, corticosteroid, IV ceftriaxone. So first, to decide the management, you should fetch the provisional diagnosis. So let us see some points. Patient is having high grade fever. So this is the way you should approach a question of clinical scenario. Just underline the clinical important symptoms. Inspiratory stridor, swallowing difficulty, and a very short history of just 4 to 6 hours. Acute high fever, stridor. So all of them are pointing towards acute epiglottitis. So if you go into little detail, it is caused by Haemophilus influenzae type B in children of a small age like 2 to 4 years, more in winter, rapid presentation as given in question between 2 to 4 years, fever, sore throat, muffled voice, inspiratory stridor. So all of this are approaching towards acute epiglottitis. So these all management, like nebulized racemic epinephrine you can give. Anti-diphtheria toxin is not in management. Corticosteroid is not given. It is basically given for the croup where there is acute inflammatory reaction and bacterial toxin. Yes, this IV ceftriaxone is the treatment of choice in acute epiglottitis. So here the most favored answer is acute epiglottitis. Treatment is you make the patient go into operating theater to establish the airway. So basically airway is the first thing you will manage in case of acute epiglottitis. What is the other important things for the diagnosis is the classical lateral X-ray. So if you see, observe the classical X-ray of lateral view soft tissue neck, you will observe a sign called thumb sign. So this thumb swollen fiber optic laryngoscopy, you see this swollen epiglottis. So in acute stage, you are not going to examine like this because it is contraindicated. You will give a X-ray, and what you can do is you are not going to intubate the patient, but you can do fiber optic if it is not condition called croup. So how you will differentiate? This time they had asked acute epiglottitis. In other time they can ask you infectious croup. So in acute epiglottitis, you will see muffled drooling dysphagia, muffled voice. Here in infectious group, you can see a barking cough, steeple sign in place of thumbprint sign, and subglottic narrowing. So here in infectious group, you will give a single dose of corticosteroid, and in acute epiglottitis, you will manage with antibiotics. Okay. Now again, some difference between epiglottis and croup. These are very basic. In acute epiglottitis, the signs, symptoms will be of very toxic, means high grade fever and everything, stridor. But in croup, patient will be little well looking. It will be abrupt onset. It will be of slower onset. Here there will be high fever. In croup there will be moderate fever. Okay, stridor it will be moderate to severe and usually mild in case of croup. Cough is usually minimal or absent, and here barking cough will be present. Speech, patient won't be able to speak, and in croup it will be hoarse voice. In epiglottitis, there will be difficulty in swallowing, and in croup, patient will be able to swallow. So these are two X-ray differences where in epiglottitis you can see thumb sign. In croup, you will see narrowing. See the narrowing of trachea here. The airway will be black. So here you can see a steeple sign narrowing in case of croup. Now, straightway moving to other question related to vertigo that I was talking about, that it was a repeat of topic from NEET PG 2019 that we had discussed. In this question, what they are saying is a clinical case of vertigo lasting for few seconds associated with head posture. The condition was treated with Epley's. What is the diagnostic test? Now in previous question they had given a picture of Epley's and asked you to identify the maneuver. Here they are saying the patient is treated with Epley's. What is the diagnostic test? So you should know everything about a thing called BPPV. Okay, so this BPPV and the different vertigo maneuvers are very important. So let us see the options: Helmich maneuver, Brandt-Derhoff exercise, Dix-Hallpais, Epley's. Now in previous discussion also I have told you about that Epley's is the therapeutic maneuver. Therapeutic is once you diagnose BPPV, you need to treat the patient with Epley's maneuver. And how you are going to diagnose? You are going to diagnose with Dix-Hallpais maneuver. So here the doctor is doing Dix-Hallpais maneuver. What he is doing is he is asking the patient to what you are doing the maneuver, means right, so right, and left, so left 45 degree, and then abruptly doctor makes the patient lie down on a couch with head tilted in angle of 30 degree down. So this is made so that the canal come in vertical direction, and what you see is you observe for nystagmus, appearance of nystagmus. So you wait here for 1 to 2 minutes and observe for nystagmus. So if nystagmus is present, you give the diagnosis for BPPV, and most common type of BPPV if asked is posterior semicircular canal involvement BPPV. So posterior semicircular canal is most commonly involved. Just remember this image. This is a procedure called Dix-Hallpike. I wanted to explain it bit detail, but due to scarcity of time, I'll post the link in the Telegram group. You can see both how Dix-Hallpike and Epley's maneuver looks like. So what we do is, once we diagnose the patient with Dix-Hallpike, like if you are doing Dix-Hallpike on right side and here the patient appears with, go towards Epley's maneuver. That means you have diagnosed it and you continue with Epley's maneuver. Okay. So if it is right side, you will maneuver for right side. So once you see how it is done, you will get a future. They can give you a clip of Dix-Hallpike or Epley's maneuver, and they can ask you what procedure doctor is doing. So it is very important for you to see the video, and I'll post it, and I'll post the link also in this comment section. So do comment me if you want the link on the comment section. Now, between the nystagmus, how you are going to identify what type of nystagmus is there. So you are doing the test, but you should know what type of nystagmus is there. So in central lesions, there will be either purely vertical or downbeat nystagmus. There won't be any latency. The duration will be persistent. There won't be any fatigability, means on repeated testing, on repeated exposure, the nystagmus will be of same amount and persistent. So brainstem or cerebellum. But for semicircular canals like peripheral lesions, it will have a torsional component, usually towards downward. So if posterior semicircular canal is involved, you will see a torsional towards the downward or vertical upbeat. Okay, there will be latency present. Duration will be very brief, in seconds or in minutes. Fatigability will be there, means on repeated testing the nystagmus will reduced. Okay, and if we see the types, means basic differences, it is here. Latency will be there in peripheral. In central, no latency. By latency, what you mean is, just after doing the maneuver, if the nystagmus appears, means with after some time, that means it is of peripheral nature, means latency is present. Duration will be short. Direction will be fixed, means towards right or left or anywhere. Okay, it will be fatigable, while the central lesion nystagmus are non-fatigable. The direction keeps on changing. The duration is more than 1 minute and there is no latency. Right? Now the other options were Brand-Herhoff maneuver. So this is a simple Brand-Herhoff maneuver. What is it? It is also done for BPPV as a home exercise. So you prescribe when the patient is presenting with recurrent vertigo, recurrent BPPV. So you prescribe him for some home exercises. So this Brand-Herhoff maneuver is just a home exercise or home maneuver for treating BPPV. So here the patient, you ask him to lie once on this side, then straight, and then on the other. Brand-Herhoff exercise. So this is also a Brand-Herhoff exercise picture you should remember for your future examination. And Helmich maneuver, you all know, it is for any foreign body obstructing in the airway, where you give the thoracic thrust at the diaphragm region, so that due to thrust the foreign body. Also one more question, one last question, where a picture was given and a syringe was being put on the lacrimal puncta. So they had said what the procedure is being done. So it is basically the nasolacrimal duct block, and what they are doing is basically they are doing nasolacrimal duct syringing, right? So they wanted to diagnose epiphora, means for investigating epiphora is watering from eye. They want to see whether this epiphora is caused due to blockage of the ducts of the lacrimal system. So that is why we do this syringing. So in case of watering of eye, we need to differentiate between hyperlacrimation and defective drainage. So that is why we lacrimal pump failure. And what you do is you give some syringing, some water from here, and you observe or ask the patient whether he can swallow, whether he can see, and whether he can feel, not see, but he can feel the water coming in his throat. Why? Because this nasolacrimal duct is opening below the inferior turbinate in the inferior meatus. Put with syringe, it will go into the patient's, means behind the throat, so he can feel that water is going. And if it is blocked, there will be regurgitation of water either from the same puncta or from the other puncta. So why it is important, why this test is important? Because if there is block, you need to operate the patient to relieve the symptom. You basically do dacrocystorhinostomy. So two procedures, one will go for ophthalmology, that is the external DCR, which is done by giving an incision externally. And what we do, ENT surgeon, we do endo DCR. Endo DCR means via nasal route, via endoscopy, and do dacrocystorhinostomy. That means through the nasal route, with the help of endoscope, without any external incision, we go and open the lacrimal sac so that whatever drainage is hampered, the lacrimal sac can drain into the nasal cavity. Okay, another option was Vedian, about Vedian neurectomy. So you all know that Vedian nerve is basically a combination of greater petrosal nerve and deep petrosal nerve. So both this greater petrosal nerve and deep petrosal nerve join to form Vedian nerve, which is also called nerve of pterygoid canal. Okay, so why this nerve is important? This nerve is very important because this nerve carries the parasympathetic and sympathetic mucosa. Okay, so this greatest petrosal nerve is for parasympathetic, deep petrosal nerve is for sympathetic. So by this Vedian neurectomy, what you can do is in vasomotor rhinitis, you can what you can do is you can reduce the nasal secretion. So as a treatment, you can do Vedian neurectomy endoscopically. Okay, so you should know. And here in the CT scan picture of sinus, this is sphenoid sinus. So I just wanted to, because CT